By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another edition of Let's Get Real with NCAN. I'm your host, Mike Wayman. Before we get into this really awesome discussion with Dr. Charles Nutting, interventional radiologist, I do want to remind everybody that we are in the midst of our Stride for Stripes virtual walk. You could go to netcancerawareness.org to go ahead and register for that. You can walk from anywhere. If you're more the in-person type and you're in the Carolinas, it's on November 3rd. We also have our Celebration of Life Gala on November 9th. On November 10th, we have our Net Cancer Awareness Day worldwide live stream with some great doctors. If you want to know anything about all of these different programs that we have coming up, definitely go over to netcancerawareness.org or go to our social medias at netcanceraware, and we'll have all that information readily available for you. So without further ado, I want to welcome a very much requested doctor, talking about a very much requested topic here on the show, Dr. Charles Nutting. Welcome to the show. Hey, Mike. Thank you for having me. I appreciate you and NCAN for this opportunity. Yeah, absolutely. So if you can, just give us a little bit of a background about you, your practice, what you as an interventional radiologist do. Sure. So I've been a practicing interventional radiologist for 25 years, been in Denver for the last 20 years, specialize in liver directed therapy and some other embolization procedures. So as an interventional radiologist, I perform image-guided procedures. We use image guidance, usually X-ray, CAT scan, or ultrasound, to identify tumors and then direct our therapy. So unlike systemic therapy that circulates throughout the entire body and is appropriate, my therapy is really focused on the tumors. And what that means to the patient is we can usually get a higher dose of therapy directly on top of the with less toxicity or systemic side effects. And Mike, the joke is, as an interventional radiologist, my mom still doesn't know what I do. I just tell her that I'm a plumber somewhere between the neck and the knees, and that usually, lets people know kind of what I'm doing. Well, it's very interesting the way the therapy works, and I've been to enough of the conferences and edited enough videos to know that it's really, really exciting work, and I do want to get into that. So specifically, did you get into interventional radiology because you were interested in the field, and in turn, how did you get involved with NETs as closely as you have? Yeah, so I love interventional radiology because first I started as a radiologist. So you have to kind of know something about the entire body with all of the imaging that's being done. So you need to know a lot of anatomy. But as a radiologist, I didn't really get to see many patients. I got to see lots of images. So I did a fellowship in interventional radiology. I could take my love of imaging, my love of patients, and fuse those two together. And right now, I would say it's one of the most exciting fields of medicine that we have. We're utilizing image guidance, so very sophisticated images. And it's like playing video games all day long. So I get to watch a big screen TV. I manipulate these little tiny catheters inside of the vessels
searching for the tumors and the blood supply. And we're using artificial intelligence now, as well as navigation, which is almost like GPS for your car. It's GPS for inside of the body. The computer can tell me where I'm starting. I can tell it where I want to finish, and then it will draw me a line of how to get there. So the technology advances are very exciting. I fell in love with treating patients, especially neuroendocrine patients, 20 years ago. And I worked with some of the legends in the field, and was fortunate to attend conferences, work with patients. As you know, neuroendocrine patients are looking for specialists who can focus on their particular disease process. Many patients are going to be around for a very long period of time. So we develop these relationships. We determine which therapies should be delivered in which order, so that we don't burn any bridges along the way. But it's become a passion of mine over the last 2 decades.
It's amazing. It's amazing. So I do want to ask a little bit about the patient side in a little bit in regard to your interaction with them and why it's so important for them to be involved with their treatment plan. But tell us a little bit about, because this is what the topic is that a lot of people want to hear about, is liver-directed therapy. Can you let us know a little bit more about the actual process, what it entails, and what's so beneficial about it?
As an interventional radiologist, liver-directed therapy is really just what it says. We're trying to treat specific areas within the liver. And when I see patients in consultation, I work closely with neuroendocrine specialists around the country, specifically Eric Liu and Al Cohn in Denver, and I'm part of the Neuroendocrine Institute here. What we're looking for is how many tumors are there in the liver, where are they located, and how aggressive are they? If there's only a couple of tumors, maybe 3 or less in the liver, then we think about a local liver therapy. And when I say local liver therapy, the ultimate local therapy is surgery, to go in and actually cut out a certain portion of the liver tumor. We can also be less invasive, where we can put needles in these areas and perform radiofrequency ablation. We could do cryoablation, microwave ablation. So heat up the tip of the needle in the area of the tumor to kill it from the inside. Histotripsy is also coming online, which is a non-invasive therapy. And I think the data still needs to come in on that, but it is very exciting. Unfortunately, most of the patients that I see have more than 3 tumors, and they're kind of spread throughout the liver. So as an interventional radiologist, I consider regional liver therapy, or treating these areas through the arteries. The tumors have a larger blood supply than the normal liver tissue, so they suck in more blood into the tumor. We can trick them and inject beads or particles into the artery, where the tumors suck in the beads become stuck in the tumor, and they can exert their local effect. So there's bland embolization, which is something that we do pretty frequently. Bland just means that the particles that we inject don't contain chemotherapy or radiation. They work just by traveling downstream, getting stuck in the artery, creating lack of blood supply where those tumors can stabilize and kind of die from the inside. An extension of that would be chemoembolization, where we mix chemotherapy with some of these beads, or an oil-based contrast that slows down the blood flow, so that the chemotherapy then dwells or sits in the tumor longer than if we just injected it directly there. And then there's radioembolization. And radioembolization is typically performed with Y90 or yttrium-90, which is the radioactive material that's attached to a very small bead that is injected, travels down into the bloodstream of the tumor. Because that bead is bigger than the capillaries, it gets stuck in there, and it exerts its local radiation effect into the tumor over the next days to weeks to try and help stabilize the disease.
Now, one of the things that does come up a lot, and it's even in one of the questions that you had sent over for prep as well, something that we've we've touched on a number of times, we've touched on it on this this very show as well, is PRRT. And a lot of people are of the mindset of PRRT being that last stop. And I just wanted to know if you could go into a little bit about PRRT, and also, is it safe to use PRRT before or after other liver-directed therapies?
That's a great question, Mike. And I think the data is still coming in. I wouldn't say that we have a large data set to look at. There are a couple of small papers looking at patients who have received PRRT before or after radioembolization liver therapy. And I know that you have a very educated audience, but PRRT, peptide receptor radionuclide therapy, is a radiation therapy that's given through the vein, circulates throughout the entire body, and then lands on somatostatin or sandostatin receptors that cover some of these tumors. So you do have to have tumors that are sandostatin positive. The good thing about PRRT is it circulates throughout the entire body and can find tumors outside of the liver, and is very appropriate. If patients have a large tumor burden inside of the liver, then we may consider doing some kind of embolization to the liver before we would administer PRRT, so that we can knock down some of those receptors. Because if you have a large liver burden, the PRRT may not have enough activity to cover the liver and the extrahepatic disease. So the safety portion of this is, can you have PRRT and then Y90, or vice versa? And looking at the data, the limited data that's out there, I would say that yes, it's safe and effective. We tend to reserve Y90 for a little bit later in the disease process. We would use chemoembolization or bland embolization early in the liver tumor process. We tend to reserve Y90 for a little bit later down the line, or if it's a very aggressive tumor. Radiation is cumulative over your lifetime. So when you receive PRRT, it depends how many tumors you have in the liver as to what dose you're going to receive. Typically, you get about 1% of the total dose of PRRT that is taken up within the liver. PRRT is typically 4 cycles, can be 8 cycles. So you have to remember how much radiation your body has seen over this time. That may affect the calculations of the Y90 that we would administer in the future. And what we're trying to avoid is any kind of toxicity to the liver itself. We want to preserve the liver function as best possible. Usually the total bilirubin is a very good indicator of hepatic reserve, or how much normal liver tissue you have. And so usually bilirubin's less than 1.5. Patients can tolerate these therapies.
Now, what other, we've talked about PRRT and Y90, what other therapies are available to patients currently besides that? And of course, we were talking about histotripsy. That seems to be the buzzword in the community right now. But what else is available to patients?
So as far as therapies that are available, I don't know that I would be an expert to speak on systemic therapies, but I can tell you that there are systemic therapies being given in tandem with liver embolization. And there was a study by Dr. Anthony that looked at everolimus administered with bland embolization. So everolimus is also known as Afinitor. It's an mTOR inhibitor that can maybe decrease some of the new blood vessel formation that happens after we do these embolizations. He published an abstract that said it was safe to administer bland embolization, which are just the beads without any chemotherapy or radiation, along with this other systemic therapy. They had very good results looking at safety. There was an efficacy paper that was also published that said these patients had significant stability of the disease over time above that of just a bland embolization. But it was just an abstract that has not been published in peer-reviewed literature.
Okay. And from a patient side, with these therapies, what kind of preparation is involved? What do they have to kind of go through to get to the point where they could be administered something like this? And also, what kind of recovery? How invasive? What are some of those things that you could share? Obviously, it's going to, recovery time and things like that are different by patient, but what's like the general consensus on that stuff?
In general, with liver-directed therapy, meaning regional liver therapy, which is an angiogram. So maybe I should back up a little bit and just say that an angiogram is a procedure where you receive conscious sedation either in the clinic or hospital. We clean off the area over your hip or your wrist and put a tiny, no incisions really, just a tiny catheter goes in that vessel and allows us to find the vessels that go to the liver. How do you get to this point? So usually you're referred in by your neuroendocrine specialist. We'll look at all of your imaging studies, whether that's gallium imaging, PET scan, MRI, CAT scan. So what we're looking for is, where are these tumors located? There's right side and left sides of the liver. If it's just right-sided disease, then we're just going to go in and treat that right side. If it's tumors identified on both sides of the liver, usually we can't treat the liver all at once. You need to have enough liver to recover on. So if somebody had disease in both sides of the liver, they would usually come in, we treat the most diseased side first, which tends to be the right side because that's 70% of the liver volume. And then you'd come back about 4 to 6 weeks later to treat that left side. These procedures can be done in an outpatient setting. So I have a new clinic in Denver where we treat lots of patients with neuroendocrine disease. There are certain things that we can do to help with the recovery with medications, both pain medicine, nausea medicine. Most patients who are being treated, so if we look at the different types of embolization, the bland embolization, the chemoembolization, and the radioembolization, the recovery is different from all of those. With a bland embolization, what we're trying to do is get enough beads into the tumor to starve it of its blood supply. Anytime you starve something of its blood supply, the body's natural response is to have some pain, to have some nausea, and you can get a low-grade fever. That's called post-embolization syndrome, very typical, and we can help control that with medications. So recovery from a bland embolization, most patients are going to feel pretty crummy for about 2 to 3 days, and then you'll start getting back to normal. Crummy means flu-like symptoms, low-grade fever, pain, nausea. We prescribe medications to help with all of those things. Occasionally, patients need to be hospitalized for those procedures. And some of that depends on the labilness of the tumor. As we're going in, and patients who have functioning tumors can have some flushing. They can have just that feeling that they get of a carcinoid type syndrome. We pre-medicate all of our patients with octreotide. And it's important for patients to ask their doctors, how are you going to protect me from a flushing or a carcinoid type syndrome? Patients who are relatively stable, we give just octreotide bolus on the table through the IV. Patients who are more labile or really have significant symptoms, we'll start a continuous IV and just drip that medicine in as needed. So most patients can be treated in an outpatient setting. When we talk about chemoembolization, that can also cause these post-embolization type symptoms. Chemoembolization and bland embolization are really dependent on where you're getting treated around the world. Some people use these two therapies interchangeably. And then there's radioembolization. So radioembolization with either Sursphere or Therasphere requires a mapping angiogram. Again, that's an angiogram. You come in, you receive some sedation, and we're just trying to inject the liver to get a lay of the land and plan where we want to deliver that radiation. Usually a couple days after that, the radiation will have been ordered for the patient. We draw up a dose specific to the patient, and we'll treat one or the other side of the liver. With radioembolization, patients tend to recover pretty well. They don't have that same pain as patients with bland embolization. Again, we do give them steroids, we give them anti-nausea medications and pain medications, but with the radioembolization, patients feel pretty good for about 2 to 3 days, in contrast to the bland or chemoembolization. But at about day 3, they start getting some fatigue or tiredness. As that radiation is doing its job on the tumors, it's normal for you to feel some of these systemic side effects as well.
Sure, absolutely. Now, I wanted to get back to what I had mentioned earlier. I wanted to know why you think it's so important for a neuroendocrine patient to be involved in their treatment. I know that you have a number of tools that you can bring to the table and stuff like that, and not one size fits all. So why would you say it's so important for a NET patient to be involved?
I've always felt that patients are their own best advocates. So really an educated patient may know more than some of the physicians that are treating them. And I think it's important to find specialists in your area. Obviously, this is a relatively rare tumor, so you want to make sure you're going to a physician that understands the state-of-the-art therapy, that works collaboratively in a multidisciplinary team. So it's important, and I think at the Neuroendocrine Institute in Denver, we have meetings monthly, but I talk with Dr. Liu several times a week and text back and forth. So I think, because I don't know all the answers, but between the team, we can come up with the answers that are best suited for that particular patient. And Mike, as you said, everybody's an individual, and therapies need to be tailored to those individuals. So whether it's systemic chemotherapy, whether it's PRRT, liver directed therapy, an educated patient can question their doctors. I think good physicians are happy to answer those questions and stimulate discussion. And it's not a cookbook. It is not that you do this and this and this. It's that you do things in an order that you're not going to burn any bridges. So you want to make sure that you're receiving the appropriate therapy for the appropriate timeline of your disease. So again, I don't have all the answers, but when patients bring questions, I'll do the research. I'll reach out to experts from around the world and get the answers for the patient. You need to be treated in a multidisciplinary setting where everybody's weighing in.
Absolutely, absolutely, and I hope it's refreshing for people to hear a doctor say, "Hey, you need to spark this conversation. You need to question things. You need to." I think that a lot of people take the doctor's word as the Bible, and that's the way it has to go, and that's it. So I think the fact that you're open to discussion and field things out to other people, I think that's super important, and I think it's great for people to hear that, because it's not something that people normally are used to hearing.
Yeah, it's humbling.
So what advice for a neuroendocrine patient? They've just been diagnosed. What do you think is the number one most important piece of information that somebody getting diagnosed with NETs should take?
So I think that the diagnosis itself is important. As you know, it takes a long time to get that diagnosis. But resources like NCAN and other societies where there's peer-to-peer, patient-to-patient interaction, again, I think it's finding the specialists. Your local oncologist may have treated neuroendocrine disease, but I think getting to that specialty level is going to get the patient probably the best care for the rest of their life, which can be a very long time.
Absolutely. Now, where do you think is the best place to find specialists? Because I know that there's not really necessarily a hub where people can find that, and some people do have a hard time getting the right oncologist to understand the disease. So, where do you think is a good place to point a new patient?
So I might be a little removed from that, Mike.
Okay.
I think that NCAN and other online resources, it's much easier now than it was 15 years ago. Honestly, I'd probably defer to you as far as that part of the patient education.
Yeah. Definitely get in touch with NCAN. Get in touch with any local community in advocacy, because you're talking to people who have experienced it, and they're going to be able to send you to the right places. So appreciate that. So in closing, I do want to thank you for joining us and imparting all this important information. I'm pretty sure that if you go onto the NCAN YouTube, there is at least one or two of Dr. Nutting's presentations on there. But hopefully we get to see you in 2025 at some point. We'd love to have you on another one of our conferences, because it's always great getting the information from you.
That's awesome, Mike. I appreciate the opportunity to spread some of this information, and I'm happy to answer any questions as they come up. Awesome.
Thank you guys so much for joining us. Dr. Nutting, thank you so much for joining us as well. And we'll see you next time on Let's Get Real.
Thanks, Mike.